Halo Jens.
Assalamualaikum warahmatullahi wabarakatuh.
Salam.
Pembicaranya akunnya apa ya, Pak?
Itu udah masuk tuh, Jens and Miriam.
Jens and Miriam ya? Oke. Ya, sudah saya jadikan co-host, jadi nanti bisa share screen.
Oke.
Pak Dwi, karena
Ya.
saya lihat banyak yang dari luar, mungkin nanti untuk pertanyaan pakai bahasa Inggris.
Oke. Ya.
Saya niatnya dari awal pakai bahasa Inggris sih, Pak.
Ya, oke.
Nunggu jam 1 aja.
Halo Jens.
Hello.
Oh, hi.
We are just right now trying to get our camera working, but it's
Okay.
Problems.
Yeah.
Can you also try to share your screen?
Sure. Yeah. Just a second. It's okay.
Oh, nice, very nice. Pak Sukri, gimana Pak? Mau langsung dimulai aja atau lagi nunggu ada tamunya sedang ditunggu mungkin?
Enggak, langsung aja silakan.
Oke. Good afternoon, everyone. Assalamualaikum warahmatullahi wabarakatuh. Welcome to the weekly seminar of Department of Physics, Faculty of Mathematics and Natural Sciences of Universitas Indonesia. Today we will have a weekly seminar that is routinely held in every Wednesday. Today we have some guests, two guests in fact, from the University of Medical Center Mannheim, Germany, Mr. Jens and Miss Miriam. So they will present some of their research and their new findings about the clinical application for CBCT, I think. And today they will share their research, and also we have some guests, other participants from all of Indonesia. So I hope you all can enjoy this seminar, and please ask question. If you are too shy to ask directly, you can write it in the chat room, and I will try to read the question, and maybe the presenter can answer at the appropriate time. So this seminar will be held from 1 p.m. until 3 p.m. So usually it's about the 1.5 hour presenting and half an hour question and answer. But because since we have two presenter, I think we can. It's up to the presenter whether they want to present from the start until 1.5 hour, or maybe they can have 45 minutes presenting and 15 minutes question and answer, and then continue to the second one. I think it's up to Mr. Jens and Miss Miriam. Okay, so without further ado, if Mr. Jens already prepared, I think we can directly start the presentation. Is it okay okay? Thank you very much. So please start your presentation. The time and place is yours.
Can you see my screen is my first question?
Yes, it's very clear.
Okay, excellent. And then we can, obviously you can hear me and you can see my screen, so we are ready to begin. Good. So what we did is just to give you a brief introduction on the scope of this work. is twofold. The first question, research question that I'm basically going to address is how to implement into clinical routine the usage of daily data. So in our case, it would be the daily cone beam CT acquired under the medical linear accelerator, and use this to adapt a treatment plan on the daily circumstances of the patient. In part 2, we basically applied this newly acquired correction method to a realistic clinical example, which would then be adaptive radiation therapy for prostate cancer stereotactic treatments. So just to give you an idea of what's about to come when in this presentation. Good. Try to click. Yes, now. Good. So the agenda, I just need to move my screen around a little. Yeah, like this. First of all, we will just, let's say, make clear what is the idea of adaptive radiation therapy and how it can be achieved. What is the clinical rationale of the entire adaptive part in this radiation therapy approach? We will discuss possible strategies for implementation. I guess most of us have already heard about the newly available MR-based linear accelerators, so this would obviously be one possible choice. And obviously one thing that we need to do is always the topic synthetic CT generation. So in radiation therapy, you need any form of image data that can later on be converted into electron densities, because only with the correct electron densities available, you can determine the absorbed dose in matter. And therefore, it is always important to have these CTs available that can be generated and calibrated. And there are obviously different methods that can be used to generate these now calibratable CTs, but we'll see more of that later on. Image segmentation. When we want to perform an adaptive radiation therapy treatment, it is of essence that we can quickly contour or perform an image segmentation, just because the patient is lying on the treatment couch and we don't have, let's say, 20 minutes to perform a manual image segmentation. Therefore, this is important in this scope. And ultimately, if there are anatomical differences on the day, we want to adapt the treatment plan. And how this can be done will also, let's say, shed light on. Lastly, we will show you one clinical application. In our department, we have mostly Electra linear accelerators, so we are showing one clinical application, how this can be realized in an Electra world. It, however, could also be done in any other environment, just because we only have these type of Linux, that's why we use them. Good. Briefly, going back one step, where are we standing right now in radiation therapy? I would say starting at the very beginnings of 3D radiation therapy. So 3D meaning the use of computed tomography data. You can say, let's say, in the 1990s, that was the age of 3D conformal radiation therapy, where first people used CT scanners for treatment planning, and they basically performed a fixed number of static beams on to treat the patient. Later on, in the early 2000s, intensity modulation was developed, and with intensity modulation, we were able to first create highly conformal treatment plans. The only problem with these highly conformal treatment plans was that they were only conformal in the actual treatment planning CT, so the CT that is acquired prior to the treatment. So obviously, and that happened in the early 2010s, people wanted to introduce some form of image guidance. That was when the actual cone beam CTs, the first cone beam CTs, were mounted on the linear accelerators to check, is the patient on the actual anatomy actually in the same circumstances as we had during a treatment planning CT scan. all of these three techniques are basically now well established all over the world. However, we assume a static patient. So they are highly conformal radiation therapy plans, but we assume the patient doesn't necessarily change during treatment, which is obviously an assumption that is made. If we go further, we now have tons of, let's say, highly accurate data during treatment, be it MR, be it cone beam CT, be it ultrasound, so different possibilities. And the idea is, can't we use this data to adapt the treatment plan either on one day, which would be called offline adaptive radiation therapy, or online, so real time during radiation therapy. In this context, people typically speak of tracking and these type of or gating approaches. This is a typical online adaptive form. So in a sense, this, let's say, newly to be developed form of radiation therapy would not only be spatially conformal, it would also be timely conformal. So at all times during the treatment, you would ensure that what you want to treat is actually being treated and nothing else. So that is basically, I would say, the idea of the next decade that has to be established in radiation therapy, to make a highly conformal treatment at all times. Interestingly, the first research article about adaptive radiation therapy already occurred in the 1997s. So basically, we very soon will have the 25th anniversary of this terminology. And from a technical perspective, it really took almost 20 years to have the tools available to really perform an adaptive treatment, which is interesting because typically in the field of radiation therapy development, things don't necessarily always take 25 years to be from first article to actual first treatment. Just to state it once here again, that is the definition that is still valid. What we have is we have a closed loop radiation treatment process where the treatment plan can be modified using a systematic feedback of measurements. So either during treatment or once a day, we acquire an image, which is then a measurement in a sense, and we use this image to adapt our treatment plans. Why is this necessarily? I've already pointed out a few aspects, but just to give you a brief clinical wrap up, well, we all know that the tumor may change its shape and size during a radiation therapy treatment. I mean, ultimately, this is the idea of radiation therapy treatments, that the tumor vanishes. If we talk about, let's say, thoracic targets and abdominal targets, we also have the problem of target and tumor motion. So regression, motion would be one thing. Another thing, which is, let's say, especially important in the head and neck region, is typical that people lose quite some weight during their treatment. And therefore the anatomy obviously changes. That's basically one example of where where the authors of this article contoured different planning target volumes at different fractions. And you can see the target volume changes quite significantly over the course of the radiation therapy course. And lastly, we also have organ deformation, gas filling, and these type of things. Typical scenario here would obviously be the prostate cancer treatments, which we have quite frequent here in Germany. And let's say based on the filling of bladder and rectum, the prostate will be moved and or deformed during the course of radiation therapy. Here's one example of a study that we are currently pursuing, a non-small cell lung cancer patient with a quite big tumor. And what we did is we basically acquired the size or the volume of the target during the course of radiation therapy. And you can see from the first treatment to the last treatment of this particular patient, the tumor volume basically halved. If we are also aware that for these particularly large tumors, the lung dose is typically the limiting factor. I mean, it would probably be a good idea to adjust or adopt during the treatment and make sure you basically have an increased lung sparing, but still maintaining dose to the actual tumor quite high. So that would also be one application that would make sense in our from our point of view. So here is a little study that was performed at Princess Margaret Hospital, I guess in 2019, and they basically evaluated among these 4,200 patients, how many patients would benefit from a treatment plan adaptation during the course of their radiation therapy. That doesn't necessarily mean on a daily basis, it just means during the course of treatment. And what was the reasons for why this happened? And again, you see already the points I've mentioned earlier, tumor-related issues, so tumor regress or tumor progress, tumor motion, and you see non-related issues, something with the surrounding organs at risk or normal tissue is changing, and therefore, let's say the anatomy or morphology is not the same, as we can see. And interestingly, they separated it by the different organ groups, and you can see, although in this particular case, lung, for example, up here seems to play a pretty dominant role, we have different scenarios all over. So there is not, let's say, one tumor entity that would benefit the most from adaptive radiation therapy. It seems like, depending on the actual anatomy of the day, each and every target can profit or benefit from a treatment adaptation. The question is more of how often this should happen and not to whether it should happen at all. Good. So now let's go on through the actual process of radiation therapy, and let's think what would need to be changed in order to, let's say, establish an adaptive workflow. So I'm referring to the normal 3D conformal radiation treatment planning workflow, which is we perform a treatment planning CT, we take this treatment planning CT and perform an image segmentation or a contouring process of the target volume and of the organs at risk. We would then go typically into the step of inverse treatment planning in the case of intensity modulated radiation therapy. Once we have set all the specific constraints, we would perform a dose calculation. And this would be, let's say, one loop as long as there needs to be improvement. And afterwards, once the plan is acceptable, we will perform our quality assurance and perform the actual treatment. So that is the standard workflow. If we now want to basically include image guidance in there, well, obviously before the plan delivery, we will have to perform any form of daily imaging. We will move the couch correctly, and we will then deliver the plan. In this particular scenario, what you can correct, so it's also some form of adaptive if you want, you can correct for any degree of freedom that is either of rotational or translational nature. So you can move the patient and you can rotate the patient, but you cannot correct for any form of deformation of the target. That would be something that only adaptive can then perform. So if we now wanted to perform an adaptive workflow, this will happen while, let's say, the image on the day is acquired. So the patient is lying on the treatment couch, you acquire daily image, then you would need a fast image segmentation, because obviously you want to be done in a reasonable amount of time. You may or may not have to be perform some adjustment because the segmentation is probably not perfect. You will then most likely want to reconstruct the dose on the daily anatomy and check whether everything is fine. If fine, you can just start the treatment. If not, you will have to adapt your treatment sequence. So eventually a plan adaptation needs to be performed. And now we have the two flavors. Either you do that, let's say, what you learned from one day, you apply it to the next day. That would be an offline approach. You can, after the patient has been treated, just, let's say, take into account what happened on, let's say, fraction number 17 and make sure that fraction number 18 is then corrected accordingly. Or you do that online. If you want to do that online, after the step of image segmentation, you will also need to perform some step of treatment sequence adaptation. And there are also two flavors known in literature. This is either the warm start or the cold start approach. A warm start would mean you take the previously acquired information, so you already have most likely a treatment plan that looks quite good. So you can probably just take this treatment sequence and modify it only a little. That will obviously be fast. Or you perform the so-called cold start, where you have to go the whole 9 yards, a full treatment plan optimization. That will obviously take a couple of minutes. However, if you end up with something acceptable, you can then perform the treatment as usual. So these would be the things that we need to care about. So we need to make the images available. We need to perform the image segmentation in a fast and accurate manner. And then we need to perform the treatment plan adaptation in a fast and accurate manner. And ideally, what we forgot is, if I say pre-treatment quality assurance here, this is obviously not feasible anymore because there is no pre-treatment treatment plan available. You will need to verify the dose somehow while the patient is on the treatment couch. That is typically being performed either via some form of transmission detector, or today people quite often use linear accelerator log file information to reconstruct the dose. So these two flavors are available. Another problem also is the question of how to accumulate these doses, because let's say now you have a dose volume histogram or anything of the day, but since the anatomy changed, one voxel is not in the same position as it was, let's say, the day before. Even worse, some voxels may not even have existed the day before. So the question is, how do you sum up these dose distribution? On a daily basis, you can check whether a plan is good or not. But let's say in a summed dose distribution, this will impose, let's say, severe problems, or may impose severe problems. Good. So let's go through it one by one. Daily imaging techniques. Just to mention all of them, let's say the one that is out there for the longest time and is already quite established is a so-called in-room CT scanner, where you have typically a CT scanner on rails, and you just move it over the patient, or in this particular example, you would, let's say, rotate the treatment couch, perform the CT scan, and then go into treatment position. It works, it is, let's say, accurate. Only problem is you need to buy 2 devices, and it's typically considered to be slow because you need to move the patient a couple of times, and well, you have to ensure that the patient doesn't move during these procedures. The other approach that has now been released is the MR Linux. So you have an MR scanner combined with a linear accelerator. I mean, this is, let's say, a very nice machine and can be used effectively. Only problem here is, since MR images are, let's say, of a completely, entirely different nature compared to CT's images, but as I've already mentioned, you need the CT information. Later on, you need to find a conversion algorithm that accurately converts your MR information into CT information to be able to perform treatment planning on it, which will itself contain or potentially contain some errors. So it's also a difficult thing. The same thing counts for the last imaging device we have here, which would be the normal cone beam CT mounted to a linear accelerator. Good news is it's relatively cheap compared to the other techniques. It's widely available. You can buy it from all major Linac vendors. However, we also have the problem that these cone beam CTs are by nature cone beams, and a regular CT is a fan beam CT. You will have certain image artifacts in your cone beam CT scanner that you will need to correct for. And that is the one thing that we are basically looking at in the following couple of minutes. Good. Just to wrap it up, what do we do usually when we perform treatment planning? We use a CT scanner and we calibrate this CT scanner, typically with some form of, let's say here we have this gamex tissue phantom, so a phantom of different tissue densities. you perform a CT scan, you know the relative electron density, and you know, obviously, by just taking regions of interest, the CT number information. And then you can acquire this calibration curve. And afterwards, for each and every patient, you not only know the Hounsfield numbers of your CT scanner, but you know the electron density in a certain voxel. That's what we want. So the idea now is to somehow calibrate our cone beam CT scans, which are way more prone to, let's say, scatter issues, because they are cones. And these type of image artifacts, we typically have an inferior reconstruction algorithm in there. And there are a couple of problems that occur why the images are, let's say, of a less quality, and they can't be calibrated to electron densities. And as I've already mentioned, those depends on the linear attenuation coefficient of a material, so the local linear attenuation coefficient, which itself is also a function of the electron density. So the electron density must be known in order to perform treatment planning. Calibration methods. Now we'll go there one by one. The first calibration method I want to mention, so how to calibrate, be it either an MR image or be it a cone beam CT, to, let's say, reflect the actual electron density information, is you just identify certain regions and you perform what we typically call a bulk density override. So you assign either 1, 2, or 3 fixed electron densities to, let's say, certain regions of interest. In this particular nasopharynx example, it would be water for the brain, so electron density 1. Then you have the skull identified, which would have 1 fixed electron density, and you would have here then the nasopharynx region, which you would basically assign air to. The good news is this is already pretty accurate. So it's a valid approach, and it has been demonstrated in literature that this works quite well. The disadvantage is, again, it's typically considered rather slow, because you will have to assign that. You can obviously do it in an automated manner, but identifying the actual, let's say, structures may be quite cumbersome. So today, this is not really being followed a lot. Another quite interesting approach that has been presented in 2016 by a group from Denmark is to really correct the images for all the artifacts that occur. So really look at what are the physics processes in the imaging steps, and how can we basically get rid of them. So typically you have, what do you have in cone beam CTs? You acquire your projection images, and if it was possible to correct for all these errors, you would have clean data afterwards. And what they mention is the lag correction. So the dependency of which gantry angle you deliver a beam and what the system thinks, this is typically considered the lag. The scatter in the detector, the scatter in the human patient, the beam hardening in the patient, some scaling issues, and the actual reconstruction approach. If all of these are corrected, you would basically have good image quality data. Has been demonstrated to work. Only problem here is also considered rather slow. So this takes a couple of minutes to perform these corrections. A third approach, and I would say today the most widely used one, is the approach of deformable image registration. So you have a calibrated image, the treatment planning CT, and another image, which would be either an MRI or a cone beam CT, and you perform a deformable image registration. So deformable image registration then gives you a vector where each and every point in one data set, where the corresponding point in the other data set is. So typically we have a little video. So this is just one image registration procedure. The outcome of such a deformable image registration is a so-called deformation vector field that, as I said, assigns one point in one data set to the corresponding point in the other data set. The good news about image registration is it's rather fast, and you have a clear assignment of where your voxels went. during radiation therapy, and therefore you can accumulate doses. So this is quite promising. The only big disadvantage of this approach is you apply a deformation of a certain quality. And in order to know, let's say, if you make an error, so this approach is prone to errors because you never really know, is this deformation now real or is it like just a software thing? So people typically try in this field to establish quality assurance for deformable image registration procedures at the moment. And let's say up to now, there has not been, let's say, a comprehensive answer to this research question, to my perception. The last approach, and the one we followed right now, is the approach of artificial intelligence. So nowadays, you see artificial intelligence in the form of deep convolutional neural networks, or in our case, generative adversarial networks all over the place as soon as you talk about images. So the idea in this particular case is you have, let's say, trained a certain network to, let's say, convert your actual either MRI or cone beam CT images into so-called synthetic CT images that have all features that the normal synthetic CT has. The advantage of this message is the actual anatomy is not changed at all. The anatomy stays exactly the same. The only thing that these algorithms do is they assign a certain electron density by what they've learned from previous cases to the anatomy of the day. And therefore, your error is not a geometrical one, as it would be in deformable image registration, but it would be in the domain of electron density assignments. And fortunately, by small errors in electron density, you don't typically get large errors in dose. So even if we are not perfectly accurate with this approach, still the dose distribution will be rather accurate, and we will see how accurate we are in the following. Good. So we've talked about image conversion. The next step I've mentioned would be the automated image segmentation approach. And I just want to mention here, not in as much detail as I've done it right now, the approaches that are used to perform a fast image segmentation that are available at the moment. The most prominent one, and where there has been the most research, is the so-called atlas-based, which also means you feed in a system 200 data sets, how they looked previously for other patients, and the system will then basically make, let's say, more or less like in a library, look up which one is the most similar and take this one. The modern version of these atlas-based approaches is also the so-called AI-based or deep learning-based approaches, where, let's say, the idea is similar, but let's say the mathematical implementations are different. But in general, this seems to be the standard approach that's being used nowadays, also for MR scans. Replanning, Miriam will be speaking in more detail about replanning. I just want to mention the general overview. There are different approaches. The first approach that was implemented in order to correct the daily treatment sequence were the so-called plan libraries. So what people performed, for example, we had a nice example about cervical cancer, where the bladder is typically in the way. So they made people come in with differently filled bladders. So an empty bladder, an intermediately full bladder, and a full bladder. And on the actual day of treatment, you would then, after cone beam CT, just check, okay, how full is the bladder? And depending on the filling state of the bladder, you would choose either treatment plan 1, treatment plan 2, or treatment plan 3. This is obviously not perfectly accurate, but it is, let's say, one way of adaptive radiation therapy. Only problem is the time that is required during treatment planning, since you need to create more than one treatment plan, is typically higher, and the accuracy may be limited. We've already talked about these warm and cold start approaches, so I will not further elaborate on that on this one. Just about to sum it up, for the replanning and evaluation, we've also already talked about fraction tracking and dose accumulation. So how to sum up dose distributions if you do not basically perform a deformable image registration step. So you always have to loop back your daily image information, most likely on the treatment planning CT or on any other given CT that you like to perform your evaluation on. And you also need to loop back your dose information of the day on one reference data set. So this is the important thing. I mean, obviously automation, and you've already get, I guess, a pretty good impression how important this is, because we need two things. It needs to be, let's say, a smooth and automated workflow, and this automated workflow needs to be reasonably fast also. Otherwise, we can't effectively treat patients on the linear accelerator. So that would be obviously a problem. And any form of daily evaluation. So let's say most people would prefer some form of traffic light check. Okay, treatment plan okay, or treatment plan not okay. Otherwise, a medical physicist and a medical doctor will have to sit for each and every individual fraction next to the linear accelerator and decide whether the plan needs to be adapted or not. So you want to have clear criteria when to adopt and when not to adopt a treatment sequence. And software interfaces obviously are horrible things. You want it in one integrated treatment workflow. Otherwise, it will cause only problems with import and export issues. Good. Adaptive radiation therapy based on cone beam. I've already told you that is what we did. And happily, last week, we get our research article accepted on this. So it now is also available as a research article. And what we did here is basically we trained a generative adversarial network, so an AI model. So typically, these trainings are done either with multimodal data sets, so in our case, cone beam CTs and CTs. And in most cases, you want paired data sets. So of one individual patient, you want the first fraction cone beam CT and the actual treatment planning CT, because they are the most similar ones. Those you want data sets as similar as you can get them. You perform the training, and this is obviously typically a big data issue, so you need quite some information, ideally in the order of magnitude of hundreds of patients. And then you can use your individually trained model on, let's say, the next patient to perform your correct electron density assignment. And then you can use this particular synthetic CT as you would use a normal CT. So you can apply the regular Hounsfield unit to electron density calibration and perform treatment planning on it. So together with the company Electra, we've basically integrated this part into a research version of the treatment planning system Monaco. We can use the daily cone beam CTs, we can generate synthetic CTs, assign the correct CT numbers, perform an automated image segmentation, also with an AI-based segmentation algorithm, and then we can decide, okay, how do we want to adapt? And Miriam will be talking about the flavors of treatment plan adaptation later on. So that would be the workflow we had in our treatment plan. Cone beam CT to synthetic CT conversion, a little just to give you some idea of how good does this work currently. So I'll open it straight away. So what we did is basically threefold. We took head and neck cancer patient, we took lung cancer patient in the thorax region, and we took a prostate cancer patient in the pelvic region. So other than abdomen, we basically tried to address all interesting body sites. And here on the left row, you can see basically the CT quality. And in the middle row, you can see the corresponding cone beam CT. And you can already say, if you compare the middle to the left, okay, image quality is heavily degraded. And let's say here you can also see at the border of the patient in this lower image, you see the typical image artifacts from cone beam CT, that they get kind of lighter in the outside region. So this obviously would need to be calibrated accordingly. And if you look on the right, these are the calibrated images. And obviously you can see the pictures on the right look way more than the pictures on the left than the ones in the middle row. So that would be, let's say, the effect of this calibration approach that we've seen here. Just to be a little more analytical, we looked at the image spectra. So we've plotted for the 3 different entities the CT number distribution over the actual volume that a certain CT number has in this data set. And these would be from the treatment planning CT, which we considered as a reference. And if you now look at the corresponding distribution in the cone beam CT, you can see they look heavily different. I mean, especially for these pelvic cases, you see they are completely elsewhere. Also for the thoracic cases, for head and neck, it would even be the best, but it's also not very convincing. After correction, this is what we got. And you see the data set looked way more similar to, let's say, the realistic scenario. It's also not perfect yet, but I guess with considering the fact that our training collective was not huge, I have the feeling there could still be some further improvement, but it seems like artificial intelligence can perform a quite good job in this for this particular application. The good news also is generation of these synthetic CTs is in the order of magnitude of 30 seconds. So it's not incredibly time consuming. Although we have to say after the synthetic CT generation, we need an automated segmentation. We may need an automated treatment planning. So also time adds up to a couple of minutes for each and every patient. So still, you really want to know for which case it is actually relevant and for which is it not relevant. One example to just demonstrate why this may be of interest and why we are interested in the particular anatomy of the day can be seen here. During here, there was this tumor on the treatment planning CT on the left of your image. And you can see during the actual treatment, there formed basically this little pocket of air. And this little pocket of air obviously has completely...
Sorry, Jens, I think I accidentally muted you. So please turn on your...
Okay, do you hear me?
Thank you. Yeah.
Okay, yeah. So I was just saying that this air pocket here can clearly be identified if you take the anatomy of the day, and this may obviously increase the treatment accuracy ultimately. So this was just one example of how this could be done. After we have converted these images, we wanted to see whether an automated imaging workflow is also promising. And what typically is done for these automation processes is somebody performs the manual image segmentation and you perform an automated image segmentation. Then you calculate the typically the quantity you typically want to evaluate is the so-called dice similarity coefficient. So you calculate basically the percentage overlap of 2 structures. A would be the automated structure and B would be the manually controlled structure. So in an ideal world where the computer and the human are doing both the perfect thing, this dice coefficient would be 1, so 100%. And here you can see for certain organs at risk in the 3 different body regions that for the lung, we actually achieved always agreements of above 80%. And you can see the arrows here, green and red image controls, they were typically, let's say, debutable whether the human or the actual computer did a better job. For the head and neck region, we had the bilateral brachial plexi did not look that good, but it's quite difficult. They're small structures, and even the human auto segmentation person has problems in finding them accurately. For the prostate, we also saw quite acceptable agreements. Only cervical vesicles was quite bad, but also seminal vesicles are not very well visible on a CT anyway. So it has to be discussed what's actually the correct one, the automated one or the manual one. So, but let's say all in all, we achieved a quite good agreement. And what we did later on in the study, we asked the human to correct the automated images, and we took the time. And even there, we were in the time of a few minutes that were needed for correction. So all in all, this image segmentation, we were able to finish it in 3 to 4 minutes. So, which obviously is some time, and that needs to be improved, but it's not, let's say, 20 minutes or something like that. Yeah, here we say a little, let's say all of the cases were in less than 5 minutes doable. Deformable image registration took us 40 seconds. So we're getting close to it. That's the picture I want to paint here. Treatment planning wise, so what we did is we took the actual treatment plan on the day, and we recalculated it on this cone beam CT scan of the day, just to evaluate. Let's say we had 2 different scenarios: the scenario treatment plan, original treatment plan on treatment planning CT, and original treatment plan unmodified on the actual cone beam CT. And then there are obviously 2 sources of errors. There may be the organ deformation error, and there may be maybe our assignment of electron densities is not very accurate. The organ error we try to minimize by taking just the first fraction for our evaluation, but obviously it will not be 0, that's clear. It's just we did not have any other reference available. And all in all, considering these 2 sources of errors, so patient is not ideally identical, and the assignment of electron densities may be prone to errors, you see basically the deviation of certain dose metrics. So let's take the green one, the D50 of the target volume, which is the median dose to the target volume. And these are the deviations for the patients we looked at. And you can, for example, see the median dose was typically well within 1% deviation. There were a few outliers, but again, these extreme outliers are most likely have to be attributed. This was a particular case of a lung cancer patient where we had quite some motion in there. So let's say the comparability of these 2 data sets may be of limited quality. But all in all, let's say it seems to be that those can be recalculated with an error of 1 to 2%. Which would be clinically acceptable to our perception. We also performed the gamma passing rates, and also they showed the similar image. We were, let's say, the image agreement of the dose distribution was quite good. So we were happy with these results, to be honest. Good. Treatment plan adaptation approaches. I probably don't want to go into that too much because I want to leave this to Miriam. And I guess we are already quite through with my part, because this will be presented in more detail in the second presentation. Let me check, do I have something left that needs to be? No, we would be here at part 2. So let me quickly wrap up part 1 in order to make sure that part 2 is then, it's clear what the idea was there. As you've seen, we have established a workflow for adaptive radiation therapy based on the daily cone beam CTs. We are nowadays able to convert these cone beam CTs into calibrated synthetic CTs, and they can be used to perform an automated image segmentation first, and then a pure recalculation of the actual treatment sequence. That's what I've just shown to you. And we've seen that the dosimetric deviations were acceptable. I mean, the next step from here on would obviously be, we are not happy with the dose distribution on this actual image of the day, and we want to change it. And in order to change it, we have performed this little study for prostate cancer patients. And I guess Miriam will be speaking about that right now. I mean, my idea would be she just explains this part, and afterwards we are open for questions, if that is okay for everybody, unless you have an urgent question right now.
Yeah, please do so. I think it's okay.
Okay, good. Then I hand over to Miriam.
Yeah, so now I will give you hopefully a good insight into how actual adaptation can be performed on these synthetic images. And here's my agenda for the second part. So at first I will speak about the adaptation processes in clinical routine that have been performed already of previous studies, and then I will just give an introduction about stereotactical body radiation therapy of prostate cancer. Afterwards, I will display my results of the research we've recently performed with the synthetic CTs and the actual detailed results. And in the end, I will come to the conclusion of the two parts. Okay, so here's a study about a recent study from this year of the patterns of practice that have actually been performed so far in the framework of adaptation. So this study collected data from almost 180 departments from 40 different countries, and they illustrated how much or what techniques have been applied for different cancer or tumor sites. So we'll have a lot of pelvic tumor sites here, for example, the bladder or the rectum, and we have different distributions. They separated the techniques into daily replanning using a plan library, an offline protocol with specific guidelines, and also an offline ad hoc strategy in case some adaptations have to be performed pretty urgent. And interestingly, daily replanning was not used that much for the prostate cancer site. It rather was dominated by a lot of offline ad hoc strategies. So here we can see on top that these strategies have been QA'd mostly by second dose engines and also by phantom measurements, rather than by using log files, which can also function for QA methods. And this gives us the overview that, yeah, a lot of development still needs to be performed, and there's a lot of different degrees of freedom that can be used still. So where are the limitations actually? The departments also made a survey, and they said that mostly they lacked of staff, so personal staff is a real issue there. They need more people to perform the actual adaptations. Also, they didn't have enough technical equipment, and the most important point, they were missing standard guidelines. So yeah, that are the actual challenges that need to be overcome to implement these adaptive techniques in clinical routine. And online replanning, so the topic actually of my part of the presentation, was only primarily performed at the MR Linac. So yeah, that's the kind of incentive I wanted to stress. And now we can actually target these problems by using the synthetic CT. Jens already mentioned that we got image quality close to the planning CT by using these algorithms to work with cone beam CTs. And we also achieved very low dose differences on the SCT compared to the planning CT. So for the important organs at risk, we were in a range of plus minus 0.5%. And we also performed a gamma analysis. And here we saw that actually the best results were obtained for the pelvis side. And these yielded the most consistent result for different gamma analysis and also for dose difference analysis. So I will be working now with only the results for the pelvic body side. A new technique that has been increasingly used for treatments of prostate cancer is stereotactical, or is of stereotactical nature. And what can be the indications for using such stereotactical treatment? Here we have a study by the research group of Lea, which was published also this year, and they compared conformal, so a normal fractionated therapy to a hyperfractionated scheme and also to ultra hyperfractionated scheme. What does that mean? Usually we have treatments with maximum 2 gray dose per day for the prostate. Intermediate fractionation or hyperfractionation would equal to at least 3 gray per day, and these ultra hyperfractionated therapies, which I used for my research, they made use of almost 7 or 8 gray per day. So that's almost 4 times the dose you usually would take for the prostate cancer. Okay, and what do we see actually? We see that all the studies had comparable toxicity and survival in the overall disease-free survival of 5 years. And they all showed more or less similar late gastrointestinal toxicity. And this really shows us that there is no actual disadvantage of using stereotactical body radiation therapy for prostate cancer. And actual advantages can be that the greater fraction size sensitivity is increased. So we actually have a lower alpha beta ratio, and more benefits can be seen in the reduced fraction number, also with regard to the recent COVID-19 pandemic, and of course, an increased patient comfort. Moreover, and last but not least, this therapy form is cost effective, and of course, the patient only has to come maximum 5 or 6 fractions to the clinic to receive actual treatment. So in the next part, I want to show you what actual trials are available. In the past 5 years, a lot of different trials are in phase 3 already for using such stereotactical treatments. So here's just an overview of what is available. They separate between different clinical stages, risks or grades of the prostate cancer. So if they are intermediate or high risk, they compare to different methods, for example, surgery or normal fractionation. And the most prominent examples of these hyperfractionated trials are the PACE, which compares to surgery and normal fractionation. Then the HypoRT study, which is more or less the same, but was initiated in the European in the European Union. The PACE trial is more concentrated on Canada and also the UK. And we also, of course, have studies like the PHART3 or Hyperflame, which are primarily used for also targeting the lymph node area, or also being used for the MR-Linac. And there are also a lot more. And here's an overview about the actual alpha-beta ratio. In the left-sided part, we see the different fractionation schemes. And it's recognizable that for the fractionation for 7 gray and for 8 gray, we have these high biological equivalent doses of 211 and 250 gray. Okay, the study design, which I chose for the research study I'm going to present, is the PACE trial. This abbreviation stands for Prostate Advances in Comparative Evidence, and it was initiated by the NHS by a multi-center phase 3 study with randomized patients, and to investigate how great the benefit actually is over prostatectomy or conventional radiotherapy. The PACE A was targeted at 93 patients, and they investigated the advantage in contrast to surgery therapy. The PACE B arm was initiated 2 years ago, or almost 3, and they included more patients and compared them to a normal fractionated treatment scheme. Now the PACE C arm is up and running. They acquired or will be acquiring 1,182 patients, and they are just now up and running and still investigating all the research. Now I will come to the different properties of the PACE C trial. So just to wrap it up, what are the actual benchmarks we used for creating this setup for hyperfractionation? The usual margin for conventional radiotherapy is most of the time 5 to 9 millimeters to receive the planning target volume, except for the posterior region close to the rectum, where the margin is slightly reduced to 3 to 7 millimeters. In contrast to that, for the PACE C trial, we used a margin of 4 millimeters in every direction, and it's also possible to reduce that margin to 3 millimeters in a posterior direction. So this is an example of what it could look like. For the PACE C trial, they usually include the 1 centimeter direction of the seminal vesicles. So not all of the seminal vesicles is included. And you get this when you add up a margin of 1 centimeter to the actual CTV or the prostate. And then you receive your clinical target volume. You add up a margin of 4 millimeters and you eventually get the red planning target volume. So this is how we constructed our PTV. Okay, so now I get more into detail on how the study design actually was of my research. I will first speak about the patient population and how the study was designed in detail. So here's an overview of more or less the eligibility criteria of the PACE C trial. There is a certain limit of PSA for the prostate cancer patients. They all have to be below 20 nanogram per millimeter. Only patients, moreover, with Gleason scores of 6 or 7 can be included, and of a maximum tumor stage of T2C. And it's also visible that some of the patients had comorbidities. So for example, diabetes, or they suffered from cardiovascular conditions. Here is now an overview of how the actual study design has been engineered and set up. So I in total used 32 patients, and every one of them had 5 daily cone-beam CTs, which were then converted into synthetic images. They were afterwards rigidly registered to the planning CT, and a standard Hounsfield unit to electron density calibration curve was applied. Then medical expert, a physician, contoured all the relevant organs, so the planning target volume and also the organs at risk. And then the interesting part starts. So the actual adaptation was then performed by taking the reference plan we used on the planning CT, and then this plan was adapted on the daily synthetic CT and retrospectively analyzed and compared to the actual reference. And this was managed by standard analysis metric and also additional metrics. So now I want you to focus in the following on the actual characteristics of my analysis. So not too much on the actual results, but always keep in mind how you can interpret those distributions in several different ways. Okay, basically, our goal was to create treatment plans that fulfilled these treatment planning guidelines. They are according to the PACE trial, and you can find them online also. And they represent the most important dose criteria that have to be fulfilled. And the most relevant ones were for the clinical target volume. So we have to cover 95% of the clinical target volume with at least 40 gray. And furthermore, mind a maximum dose of 48 gray. We have to fulfill a second prescription dose of 36.25 gray. And also the D98% have to be above 34.4 gray. Two more important dose criteria to fulfill are for the organs at risk. So the rectum only at most needs to receive 2 cubic centimeters for 36 gray, and a maximum of 10 cubic centimeters of the bladder have to be receive the dosage of 37 gray. So these were the 6 most relevant dose criteria according to the PACE trial. The next step was generating a new template of this stereotactic treatment in Monaco. Of course, we had to fulfill these dose criteria, and we tested this template in the Monaco research version of 5.17. We made several runs actually to have a standard deviation and to test for the whole range of patients that were available in our case. And we also took a look at the rescale factor. Most challenging, we noticed, was that there was a very small 4 millimeter margin between the clinical target volume and the planning target volume, and also the control of the bladder and rectum coast function. So this is the actual Monaco treatment planning template we used in the end. And here we see that target penalty and serial coast functions dominated the complete optimization process. This is an example of an actual dose distribution. So we see here in red the 40 gray prescription dose isoline, and it covers more or less the clinical target volume. And it's also noticeable that there's a very small margin to the orange region of 36 gray, which covers the planning target volume. Okay, the next important part is how can adaptations be performed with a priori information. We used warm start optimization processes for this purpose. What is a warm start optimization? This procedure makes use of existent information from a specific reference plan. This can be either fluence or monitor units, different beam angles, and also MLC shapes or even weights. So for every single segment and control point of the reference plan, we have information. And of course, we want to use this information to not have to be starting completely from scratch for a new adaptive plan on the daily anatomy. So now we take this existing information and we only apply certain modifications to reach a reference goal, those on the actual altered anatomy of the daily situation. And then we can restore this reference dose distribution of the planning CT. And this can be handled by so-called segment aperture morphing, which in the following will be abbreviated by SAM. And here we see an example of how this segment aperture morphing can work. So we take the actual MLC shapes reference plan, and we compare the new target of the daily synthetic CT to the target shape on the planning CT. And by this comparison, the MLC shapes are morphed, and this depends on their actual geometry in relation to the target shape. So leaves that actually expose the entire tumor more or less preserve their position to the target shape, and leaves that are partially exposed, they preserve their position relatively and can be altered, which you can see on the right side of this picture. And of course, there are several different degrees of how elaborate this warm start optimization procedure can be. So let's take a look at that. Here are the different segment aperture morphing techniques of Monaco. So we have a certain pre-treatment situation, and for every situation, there is the beam's eye view visualized. If we would apply this same MLC shape in the beam's eye view to the daily situation, of course, in this scenario, we would not adequately hit the target, and the dose distribution would not be sufficient or not good enough. And then we have the case where we apply a second aperture morphing and a modification of the weights. So we actually optimize in a new way the monitor units of our reference plan, and we see, okay, more or less we hit the target now in a better way, but it's not sufficiently enough still. And on top of that, we also could perform an optimization of the shapes. So in this scenario, we actually alter the MLC positions, and now it's clearly visible that we more or less have an optimal fit to the daily anatomy. So this would be the ideal scenario. Here's an example of how the actual factors look. You can tweak in the optimization console of this segment aperture morphing. So you can control the maximum iterations of your weight optimization, of your shape optimization, and the combined ones. And here we really reduce them to a minimum. So actually they are around 250. And here we use a maximum of only 50 iterations, and the combined ones only used 5 iterations in total. And this is an example of how the optimization console looks in the Monaco research environment. So you can define your workflow here in the top. You can choose the image on which you adapt on. And of course, and most important, the plan that holds the goal distribution. So this always needs to be defined in order to get your warm start optimization up and running. We, of course, need also to define the daily target planning volume and the technique we want to use. And here we also made use of a maximum leaf change of 3 centimeters. And basically, that's all you need to define how your warm start optimization is going to be performed. Okay, let's take a look at the actual adaptation approaches we made use of. We compared 4 different scenarios. At first, we took a look at the simulation of an image-guided treatment. So we copied only the reference plan with no segment aperture morphing. We just took it from the planning CT and copied it to the synthetic CT. We made a rigid registration and used the IGRT matched ISO. So this equals the situation that is currently being applied with no adaptation at all. Secondly, we performed a segment aperture morphing, and we optimized the weights of the plan, so the monitor units. And for this, we used the ISO center of the daily clinical target volume. In the end, we rescaled this plan to cover 95% of the target. A more elaborate adaptation was then applied in the third approach. We performed segment aperture morphing with an additional optimization of the weights and shapes. So here also the MLC shapes were modified, and we used the same isocenter and also rescaled this plan. The last adaptation approach we investigated was a full adaptation. So we performed a complete re-optimization of the plan with the same IMRT constraints like the reference plan on the planning CT. And again, we also rescaled this. So what was the actual intention? We tried to investigate how much can we actually gain from different adaptation scenarios by applying different degrees of warm start optimization procedures. So now I come to the results of the study. At first, we take a look at the dose distributions of an example patient. So here we see the reference plan on the planning CT with the respective isodose lines and the important structures. And yeah, of course, the most important ones that are close and related to the target. So we have the rectum and the bladder, which are most important also for fulfilling our dose criteria. Then we have the synthetic CT on the left side. We see the completely re-optimized plan. And on the right side, we see the IGRT plan, so the non-adaptive plan. And it's recognizable that the non-adaptive plan clearly shows some hotspots, which are not very good. And also the 40 gray isodose lines are clearly not conformal to the actual target shape, and they even reach into normal tissue and into the bladder, which is visible here at this anterior side of the dose distribution. What we then actually did, we investigated the spatial dose information by creating some dose difference maps. So here we subtracted the non-IGRT and non-adaptive plan from the ART1 approach. And we already see by this first warm start approach that a lot of the regions here in the anterior region of the bladder get spared. And also this rectum PTV interface shows a lot improved dose distribution. Then we also did this dose difference maps for the other two adaptation approaches, and it's clearly visible that the more elaborate the adaptation is, the better the dose distribution gets. So here in the ART3 approach, it's visible that a lot of soft tissue is now spared, and also this rectum PTV interface is much better and receives even up to 8 gray less dose. Okay, a second method and a very common one to investigate the dose distributions of different plans is the creation of a dose volume histogram. And here we see an example of the IGRT, the non-adaptive approach. And it's clearly visible that there's a wide spread of standard deviation, especially for the organs at risk, but also for the two target volumes, meaning the CTV and also the PTV. This non-adaptive approach was performed in less than a minute, so 0.8 minutes in total. And of course, it clearly showed some deficits here. Already the ART1 approach managed to clearly improve this dose distribution. So the organs at risk were spared in a much better way. But we also created some little hotspots here in the target region. Nevertheless, you can all see that these standard deviations were clearly reduced. So we have already generated a fundamental benefit over this non-adaptive approach by applying only a modification of the segment weights. The ART2 approach, so the segment weight and shape optimization, took a lot longer. Almost 5 minutes were required to perform this approach, but we gained also a little bit of target coverage here, and the dose hotspots were not that much existent here. The last approach, the complete re-optimization, almost took 7 minutes, but the benefit of that was we really got a very improved organ at risk sparing. So especially the high doses here of the rectum and bladder were much better compared to our non-adaptive approach. And we also achieved a sufficient target coverage. Okay, so besides these dose volume histograms, there's also a method to investigate specific dose criteria. And now we come back to the actual PACE guidelines. So another additional analysis we performed was just focus on fulfilling these specific 6 relevant dose criteria, which I mentioned before. We therefore created box plots of the different plans, and these reflect in total 160 different plans per approach. What do we see here? This is an example of the prescription dose of the clinical target volume, and we have the reference plan on the left and the 4 different adaptation approaches following. And we clearly see that the non-adaptive approach was not sufficient at all. There's a wide spread of doses, and only the 3 adaptation approaches managed to really fulfill this target criterion. Moreover, we analyzed the maximum dose, and here we see that again, the non-adaptive approach reached maximum doses of up to 49 gray, and the other ones also, they are much better and managed to achieve doses in the green area. So every graph, which I will show in the following, is structured in such a way that the red background is not good and over the maximum allowed variations of the PACE dose criterion. The yellow area reflects the intermediate results, and the green area is the optimum range of the PACE dose criteria. Okay, so let's take a look at the planning target volume. Here we get a similar impression of the performance of the different adaptation approaches. So again, the IGRT non-adaptive approach was not sufficient in this case, and the same is visible also for the prescription dose of the planning target volume. Most interesting are now the organs at risk. So how did the 4 adaptation approaches perform for the rectum and bladder? Here we see that the IGRT non-adaptive approach had a very large spread of doses, and even the interquartal range was up to 21 in this case, 21 cubic centimeter, and only the adaptive approaches were able to fulfill the guidelines with mean values of 5.4 at most for the complete re-optimization. And for the rectum, we get a similar impression. Here, the non-adaptive approach also performed worst, and only the ART3 approach, the complete replanning, managed to achieve a dose of the rectum for 36 gray of 1.3 cubic centimeters. Okay, so let's continue with additional metrics. So now you have to keep in mind that there are different ways to analyze your dose distribution and compare different plant characteristics. So far, we got to know the common approaches, that being dose volume histograms and also specific dose points. In addition to that, you can apply some kind of quality score, and we decided to do that in order to have a more realistic and fast way to evaluate actual treatment plan quality. So now we did the following. We summed the relative deviations if a dose criterion of the PACE-C trial was violated, and if it was completely fulfilled, the plan got a score of 0. So this means a plan got scores the more the dose criterion was violated, and it received a 0 for being completely fine. And this is displayed in this diagram. We see the quality score, and here on the x-axis we see the 6 different PACE criteria, being the CTV, PTV, and also the 2 organs at risk. What can we see here? It's clearly visible that the non-art approach received the highest scores for all of the different scenarios and different criteria. And of course, the most elaborate replanning got the lowest scores here, being in dark blue. And we can now separate actually between the quality of different replanning approaches. So in total, the accumulated quality score was almost 12,000 for the non-adaptive approach. And already by the segment aperture morphing with modification of weights, being the ART1 approach, we reduced that score by almost 76%. If you apply also a modification of the segment weights and shapes, you can achieve a similar benefit of 73% reducement of the quality score. And as expected, the most elaborate approach of replanning almost reduced the accumulated violations by 91%. So this is a measure of categorizing the different adaptation approaches, and also we could yield from that most of the benefits of the replanning approach are actually located in sparing the bladder and rectum organs here. So we have more amount of almost 93% average benefits by applying a complete replanning to the actual reference plan. In contrast to that, this ratio is twisted. So the ART1 and 2 approach more focused on improving the target coverage by almost 90%, whereas the organ at risk sparing was only present by 78%. So you hopefully see that by calculating this quality score, it's additionally possible to really characterize the specifics and also to give you some kind of guidance when to apply which adaptation strategy. So actually, if you just want to have a quick adaptation, you basically shoot for the first approach. And if you really want to achieve a better sparing of your organs at risk, you probably will have the trade-off of calculating more and almost 7 minutes. But of course, you also get a much better sparing of your organs at risk. Okay, here is another heat map diagram of how this treatment score can be applied not only to the dose criteria, but rather to every single treatment plan. So what we now did here is we summarized and accumulated these 6 criteria per treatment plan of the whole patient collective. And it's really visible that for the non-adaptive approach, almost every plan failed for the total patient collective. Only 2 or 3 patients really exhibited fine treatment plans. And of course, this was really improved by applying the ART1 approach. So there are only a few patients left that suffered from bad treatment plans on every synthetic CT. And as expected, for the full replanning in ART3 scenario, we achieved almost scores for every treatment plan below 10, unless for the 3 outlier patients, which can be identified here by these 3 red arrows. And then hopefully it's also clear that by this measure of quality score, you also get a quick impression of how your total patient collective can be evaluated. And also with the heat map coloring, it's a very, let's say, efficient approach also for the physician, for example, to quickly evaluate a treatment plan. Okay, furthermore, we applied another measure additional to the dose volume histogram and the quality score. We wanted to evaluate eventually how much does the interface overlap region of the organs at risk with the planning target volume affect the actual dose distributions and of course the dose criteria that are relevant for rectum and bladder. So what we did is we calculated the overlap ratio between the rectum and the PTV and the bladder and the PTV and averaged over the whole patient collective. We got the result that 7.5 cubic centimeters on average overlapped with the PTV in relation to the bladder. And for the rectum, these were 2.7 cubic centimeters. Furthermore, we wanted to define some kind of prediction in order to have an action level. So imagine you have the patient lying on the table and you have, of course, as I presented, different available means of performing adaptations. So you have a segment weight optimization, which is very fast, and a replanning that takes long, but manages to spare your organs at risk in the best way. So now the physician and also the physicist have to choose which adaptation strategy is best to apply. And here we wanted to present a measure and a very efficient way to manage this decision in the daily situation. So what we did is we calculated a ratio between the coincide events of plans that were actually near the maximum overdosage for the rectum and bladder, and at the same time had a very high overlap ratio for the bladder and rectum, divided by the actual overdose plans for the both organs at risk. And what we found was that for the non-adaptive approach for the bladder, almost 73% really were able to predict this potential overdosage by taking the overlap ratio, and this even amounted up to 100% for the 3 adaptation approaches. On the other side, for the rectum, at maximum 89% in case of the replan scenario could be predicted by this overlap volume for the rectum. So this means that actually by this very easy metric of calculating only the overlap volume between my target volume and the respective organ at risk, I'm able to say, okay, if this ratio and overlap is very high and over average, I have to be careful with the actual daily dose distribution, and I would rather tend to go for a more elaborate adaptation approach to really spare my organs at risk sufficiently. Okay, I will not go into detail here for this outlier because this was just a special case. So eventually we come to the conclusion. What did we learn today? In the first part, Jens presented that there are a lot of indications for applying adaptation, adaptive radiotherapy, and a lot of strategies are actually available that we have to choose from. Most challenging were the time and the costs, and also the software interfaces. So we have to manage a lot of different techniques and a lot of different softwares at the same time. And of course, we should not forget about performing the quality assurance in the end before applying the actually dose delivery to the patient. Moreover, a solution for these challenges was offered by the individual synthetic CT models at Maya in Monaco. Processing of chromium CTs was possible in less than 30 seconds, and the results were reliable and comparable to actual planning CT quality. Moreover, the deformable image registration for performing the contouring step took less than 40 seconds, and with manual correction, it was possible to perform the complete contouring of a data set in more or less 5.2 minutes. On top of that, we saw that the dose calculations were very accurate. We achieved gamma pass rates above 98%, and target metrics only varied between plus minus 1.5%. With regard to the second part, it was visible that the non-ART approach, so the conventional image-guided radiotherapy, was insufficient for performing stereotactic therapy for the prostate. And in contrast to that, all three adaptation approaches were able to restore the actual reference dose on the planning CT. We also took a look at the benefits of ART techniques versus image guidance, and we yielded and obtained accumulated dosimetric benefits of up to 91%, also by applying the quality score. Of course, you have to choose between different flavors, which fit best to the daily anatomy and daily situation of your patient. So several techniques had specifics and advantages. Modification of the weights was the fastest method, and it only took maximum 1 minute. The second approach, R2, also modified the shapes, and the benefit of this was that less hotspots were created and the best target coverage was obtained. The full replanning was most time consuming with almost 7 minutes, but also on the other side achieved the best organ at risk sparing. Last but not least, additional metrics beside the dose volume histogram and specific dose criteria could help defining action levels, which is very important for clinical routine and which is able to function as a guidance for when to apply which adaptation strategy. All in all, I hope we could give you an insight into our research, and we hope, of course, that these results were able to build kind of a framework for the end-to-end workflow and also to function as a realistic approach of implementing adaptive radiotherapy techniques into clinical routine, especially for C-arm Linux. Yeah, so that's it from our side, and we are open to every question you have.
Thank you very much, Miriam and Jens, for the presentation. So I will read some of the questions that's already written in the chat box. So the first one, I think it's from Diana from Malaysia. So she asks about, can you elaborate further on what are the difference between atlas-based segmentation and deep learning-based segmentation, as both need some data or samples to learn before producing the output?
Yes, that is absolutely a perfectly valid question, and it's actually quite difficult to put it in a few words. But let's say input-wise, both of them function in a similar manner. Both of these methods need image data set. The only question of then is how do you process the data? In the form of atlas-based, basically the image information is processed in, let's say, with, let's call it conventional algorithms, whereas in AI-based or deep learning-based algorithms, you typically use so-called deep convolutional neural networks, and you build these networks with certain classifiers, and you then process the information to extract certain features out of it. So input and output wise, it's actually the same. The question is what happens in between, and yeah, this gets really, let's say, sophisticated to go into concrete detail. But let's say, to give a short answer, I would say one is using generic algorithms, whereas the other is using these typically convolutional neural network ideas, where you apply certain levels of neural networks, where you specify certain classifiers to extract certain image features, and you then basically obtain information, let's say, on how to modify your images.
Okay, Miss Diana, is it clear enough? Okay, she also has second question. It's about, may I know how long did you take to come out with an accurate or good neural network for your prediction? How did you validate your model?
Yes, I mean, the thing is, we actually developed this model together with the company Electra. So we only did parts of this evaluation. However, we currently in our research group have also PhD students who are working on, let's say, generating neural networks. One of the topics there is the prediction of those based on a neural network. So I can probably refer from this. So you have different levels. Let's say getting used to working with artificial neural networks nowadays is not difficult anymore, you have to say, because there is a lot of mostly Python language-based software out there. So PyTorch, for example, is a class library for artificial neural networks. You can use them, and I would say a physics graduate student can get used to working with neural networks in a couple of months. That's the thing. The difficult part, obviously, is the one that is dependent on the research question, which is then, let's say, creating the architecture of these neural networks. That is very difficult to answer because it depends on, as I said, on the research question you apply. But from my experience, this typically also takes a couple of months. What was quite time consuming in our particular example is you saw that we used quite a lot of data, and you basically have to acquire this data, you have to download it, you have to anonymize it, and so on and so forth. So I don't know, all in all, it took us weeks to just compile these hundreds of data sets. And typically you want to have a different learning collective compared to the collective you are later on using for evaluation. And that was, let's say, quite a time-consuming task to acquire all this data. You need to clean up the data. You can't take every patient because some patients have specific features that are not suited for the training and so on. So that was something that, let's say, ultimately took us months to get high-quality data. So these are the three big parts, I would say. So getting to know the system itself, applying the system, and providing sufficient input data to generate an accurate neural network.
Okay, there is another question from other participation. Okay, this is from a student from our department. He said that how is the outcome comparisons between SBRT and conventional high precision radiotherapy for prostate cancer?
Yeah, I hopefully can answer this question. So there's pretty widespread outcome for this. It depends at first on the study design you choose. So they all have different ultra hyperfractionation schemes. So depending on, let's say, if it's hyper-RT or PACE trial, they all have slightly different outcomes. It's comparable. They have comparable 5-year disease-free survivals. And there are a lot of research articles available for different flavors of ultra-hypofractionation for prostate cancer. So usually, of my experience speaking, if they have some effects that are related to the applied radiotherapy or stereotactical body radiotherapy, they occur, they occur earlier in the treatment course. So usually they suffer like already half a year after the radiotherapy from side effects, but usually they are of the same amount as the effects from normal fractionated therapy. And in the end, after 5 years, they more or less equal out regarding the two different treatment regimens. Is this sufficiently enough answered?
Okay. Thank you very much. What about?
I'm sorry. I just wanted to point out, let's say, to give you an impression why we decided for stereotactic body radiation therapy. I mean, it is, let's say, highly debated right now in literature whether higher fractionation schemes is probably better for treating patients, especially for prostate. But on the other hand, you've seen all these adaptive workflows. They still, even though the algorithms got faster, they still are quite time consuming. So, which is why ultimately we decided to take for a treatment technique where only a few fractions are delivered, because otherwise we believe at the current point in time, this will just take too long. So a normal fractionated prostate cancer treatment of 30 or 35 fractions, doing this procedure every day, on one hand, will take a lot of time. And on the other hand, it will average out the effect. Whereas when you only have a few fractions, let's say 10 minutes is not a big thing overall, additional time. And if you make one error in one fraction and you only have 3, 4, 5 fractions, this will be way more severe. So that's why our belief is that, especially for hypofractionated radiation therapy schemes, these adaptation approaches make more sense at the moment to apply. And that's also one thing I believe the MR-Linac community is currently, let's say, pursuing this approach.
Okay, thank you very much for the answers. Is there any more question? If you have question, please turn on your mic and ask it directly.
I will add some question. One question.
Okay. Okay, please.
Thank you for your presentation. Very nice presentation. I want to ask you about the in the conclusion. I think you mentioned that for the manual is 5.2 minutes, and for the deformable image registration, I think around 40 seconds, something like that. But I show also for the conclusion that For the gamma index analysis for 3 mm 3% is more than 98%. Is it this is for manual, or this is for the last technology uses for the AE or artificial intelligence or the deformable? I asked about it, or both of them, or manual also more than of 98%, something like that. Thank you. I'm Supri speaking from UI.
Okay, so Mary, maybe it was a little bit confusing. So what we actually did was we created the first set of structures by performing this deformable image registration. So you have to you have a point where to start from for your manual editing. So this took 40 seconds, and with the physician performing the manual correction afterwards, it took 5 minutes. And we only analyzed the dose for manually corrected structures. So what we did was we compared the actual daily anatomy with manually corrected structures to the reference anatomy of the planning CT. And this comparison yielded a gamma pass rate over 98%. Of course, on the other side, also these daily variations of the structures is included in there. So the 2% deviation, which we have here, also reflects the difference between the two daily anatomies. But we only try to work with actual manual edited structures and not integrate this inaccuracy of the deformable image registration into analyzing the dose distributions.
Oh, okay, thank you very much for your confirmation. Thank you.
Okay, is there any other question?
In chat box.
Ayo Pak Supri. Is
Yeah,
there any
is
more
one
question?
question. In the chat, there is one question.
In the chat.
So, which type of method we use for image segmentation, I assume, is the question here. Oh yeah, okay. Okay, which algorithm and let's say program application we use for the image segmentation. So what we currently use in this is actually inside the Electa portfolio. So from the Linux vendor, it's however, it's not a commercial version, it's a research version of theirs, because we have a research collaboration, which is within the so-called Admire package. This is a dedicated package for this type of segmentation. However, you are basically right, there are several free versions of automated image segmentation available. But to be honest, my knowledge on these is rather limited. We have only the one from the Linux vendor available here. But yeah, that I assume once you perform literature research, you will also find MATLAB, Python, whatever based free automated image segmentation algorithms. Do you have any further?
No, that's basically all. They, from Electa, engineered the algorithm to be more kind of a hybrid approach. So it's a mixture of different algorithms, so kind of daemons, kind of also parts of structure weighted parts are in there. There's also a term that especially regards the bladder function in all of these segmentations. So it's especially good for prostate patients. But yeah, so the specifics are also in the Admire manual. Yeah.
But let's say this is also a topic that is quite let's say put a lot of research interest in at the moment. And if I remember correctly, there are even these competitions where Everybody gets, let's say, a data set, and then they perform image segmentation, and at the end of the day, they perform these quality metrics among each other. So yeah, there is quite a lot going on at the moment in the field of automated image segmentation. And it's always a difficult thing to evaluate accurately because you never know what is the actual truth in a patient. So if you compare the segmented images of several different medical doctors, you will also see a quite high variation of interhuman accuracy. And with, let's say, coming above dice indices, so overlap ratios of more than 90% is a quite demanding task, because yeah, well then, yeah, it gets difficult if you don't have the truth. So if you really know what's going on, and this is typically really not the case in realistic patient scenarios.
Okay, thank you very much for the answer. Is there any more question? Hello? Is there any more question? Maybe the last question. I think we have the seminar will be held until 3 p.m. So I will give one more chance to ask the last question. Maybe from Seno, from Dwi Seno, Mr. Dwi Seno. Pak Dwi?
Yeah. So, first of all, thank you and congratulations for Miriam already published the journal. So in this adaptive plan, do you because I think the prostate is the easy way for the planning. So is it there is other maybe other site that can be potential, can be adaptive. So
Yeah. Absolutely.
Yeah, of course, yeah. So the first goal was to kind of generate this proof of principle for the most obvious tumor site, which is actually prostate cancer, and most suitable because it has the best homogeneity amongst all patient collectives. Nevertheless, we also have 2 more research studies going on at the moment for investigating the thorax site, because as you saw earlier, we had these SCT models, not only for the prostate, but also for thorax and the head and neck body side. So these 2 are also being currently under investigations. And of course, they have other challenges to overcome. So the lung tumor usually shrinks during the course of treatment, and the head and neck patients suffer from weight loss or also outline variation. And we have first results, but of course we want to test how these segment aperture morphing techniques can work with regard to these specific thorax and head and neck body sites. So this is our goal for the next year, let's say.
okay.
Yeah, exactly. I mean, I would say exactly basically the same thing. So it's a more step process. First was getting the images to work in a software environment. Second is perform these adaptation in the environment we understand. That was prostate, because as you mentioned, it perfectly correct. It's rather easy to understand. Yeah. And now we really would like to go to the more complex topics of head and neck cancer and let's say the larger lung cancers. For lung cancers, let's say this will be the next topic. For head and neck, we have the fewest experience, but for the lung cancers, we have already quite some experiences. And there, yeah, you get a lot of different problems. But what we in particular think here is, there was this famous RTOG trial 617, where they compared the 60 gray in 2 gray fractions versus 70 something gray in 2 gray fraction doses. And they come to the conclusion in 2016 that people who receive a higher dose, because non-small cell lung cancer is supposed to be rather radiation resistant, the higher dose doesn't yield a higher survival. Why? Because with a higher dose, not only the tumor is cured better, but also the, let's say, normal organs at risk, lung and heart, are damaged in a more significant way. So our idea for this adaptive approach would be, can we increase the dose to the target in a larger lung cancer patients, while we still maintain, let's say, a reasonably low dose to the organ at risk, the lung and the heart, basically. So that will be, let's say, an interesting topic, but yeah, we are currently under, let's say, investigation and preparing all information on that.
Thank you very much for the answer and also for the question. I think its time is already closing to 3 p.m. I would like to ask Professor Terry to give some closing remarks. Professor Terry? Pak Terry?
Yes.
Okay. Mr. Jens, please, can you turn off your sharing screen? I would like to share some screen. Miriam, sorry, can you turn off? Okay, thank you very much. Okay.
Hi, thank you very much for this this chance.
Udah kelihatan, Pak?
Yeah. Okay, now this is very good. Thank you very much for Dr. Jens Fleckenstein and Dr. Miriam Eckel from University of Heidelberg. I know that Heidelberg is very understood the start, yeah.
Absolutely.
Yeah, ich habe in Mainz gewohnt für 6 Jahre lang, yeah. Yeah, I have studied in Germany and I got a PhD there. I know that Heidelberg is very nice city. In fact, it is a tourist city. And thank you very much for this comprehensive, nice, and very inspiring talk from two of you, Dr. Fleckenstein and Dr. Eckel. Herewith, I would like to present the certificate. This is only maybe for administration, but it is important because this is what we can give to you online. Yeah. Thank you very much. And Padam, can you show the next certificate?
Okay, Pak.
Yeah.
Yeah.
Okay. Ja, to Dr. Miriam Eckel, danke schön für schöne Beitrag heute.
Yeah, thank you very much for inviting
my German, I think getting lost after staying in Indonesia for too long. Okay, I thank you very much also for the audience for this opportunity, and I hope that the talks can inspire you and also can give you a very good horizon in this medical physics knowledge. Thank you very much. Once again, thank you very much. Okay, Pak Adam, thank you.
Okay.
Thank you.
Thank you very much for having us.
Thank you.
Okay, thank you very much all for attending this seminar. And if you have prolonged question that that is still not yet to be answered, you can ask directly to the Jens and Miriam to the email. You can search for the email and ask directly to them. And also, if you want to review the presentation, you can look up at the YouTube of the Physics Department, Department of Physics, Universitas Indonesia. It is available on YouTube, and you can rewatch the recording there. And thank you again, everyone. Thank you, Dr. Eckel and Dr. Frankenstein. And see you again, everybody, in the next Wednesday for the same seminar, the December 2nd. Okay, see you all and have a nice afternoon. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Jens. Thank you, Miriam.